let's suppose this is the nephron and this is the capillary loops. Blood enters from renal artery on this side and leaves from these efferent arterioles, and the blood circulates down through these peritubular capillaries. This is the peritubular capillaries that travels along with these nephrons like this. So these peritubular capillaries supplies oxygen, ATP to these glucose to these tubular epithelial cells. These supplies capillaries to these tubular epithelial cells the oxygen, glucose and other nutrients, and it takes carbon dioxide outside from these tubular epithelial cells and carries along with it and opens into renal vein, and thus renal vein opens inside the inferior vena cava. So this is one nephron. And how many nephrons total we have? We have 1 million on one side and 1 million on side. So total we have 2 million nephrons in our body. And these nephrons are compacted inside the kidney. So kidney is a collection of nephrons. So the outer part of kidney is called cortex and the inner part is called medulla. So let's suppose these are the cortex and this is the medullary portion, and here renal artery opens and renal vein is drained outside. So these, you know that renal artery divides into multiple arteries, like interlobar arteries, arcuate arteries, and like this. And this makes the afferent arteriole, and this afferent arteriole makes a capillary tuft and thus exits into efferent arteriole. And here, you know, there is Bowman capsule, and that makes the proximal convoluted tubule, and this loop of Henle goes down in the medulla, and this again turns back and comes back here, and distal convoluted tubule again comes in the cortex. So these outer portions like proximal tubular epithelial cells, you know, they absorb maximum of the molecules that are filtered from the capillaries, like glucose, amino acids, protein, phosphate, sulfate, whatever. So they are metabolically active cells, so they need most oxygen supply, and when there is any decreased perfusion to the kidney or any insult, then those proximal tubular epithelial cells are prone to get damaged. So if there is any shock or any decreased blood supply due to hypovolemia, so then these proximal tubular cells get necrosed, and if generally in this person there is necrosis does not occur in medulla. Generally the necrosis occurs in cortical areas, because there is high demand of ATP. Those epithelial cells require ATP to do their job. So if there is any injury to any cell in these portions, we call kidney injury, and if it is acutely happened, then we call acute kidney injury, and if it is happened in chronic long duration of time greater than 3 months, then we call it chronic kidney disease. So why do you need to detect injury to the kidney in early stage? Because if we can intervene earlier, whatever toxins, drugs that we have administered and that is causing damage to these tubular epithelial cells, if we can remove those offending agents, if we can push some volume, if it is volume depleted, or if there are other comorbidities like cardiac failure, liver disease, liver failure. So if we can identify those and manage those, we can prevent these necrosis, acute tubular necrosis, and these AKI going into AKD and thus CKD. And if a patient develops acute kidney injury, then there is high chance that he goes into CKD. Even he recovers in this time period, there is high chance that he will have chronic kidney disease compared to other healthy persons. That's why we have to identify acute kidney injury in the early stage and intervene there to halt the progression of this kidney injury progressing towards failure stage, towards end stage. So what are the currently available markers that so that we can know that there is some insult to these tubular epithelial cells or glomerulus? So the common and popular serum marker is creatinine. So we use creatinine, serum creatinine. We use urea, serum urea. In urine we can use fractional excretion of sodium, fractional excretion of urea, and other non-invasive and that we daily use in our hospital setting is urine output. So these are the currently available markers that define that any injury has happened to these nephrons tubules acutely. But what is the problem with these currently available markers? Let's suppose you are filtering 7 liter urine per day. From, you know that our GFR is 125 ml per minute. So if you calculate in day and it comes to 7 liter per day. So you are filtering 7 liter per day. But let's suppose you are reabsorbing 5 liter per day. So what will be your urine output? You will get 2 liter per day. So even if there is injury to these tubules and these tubules are necrosed, so they will not be able to reabsorb those urine sufficiently, and you are excreting 2 liter per day. And even if there is injury, you are not able to detect it with the definition of urine output, that we generally say that if urine output is less than 0.5 ml per kg per hour for 6 to 12 hours, then we define as acute kidney injury. But did you see the fallacy of using urine output? Even there is not oliguria, there can be insult to the kidney. And now let's see what is the fallacy of using creatinine for detecting kidney injury. So let's say a 27-year-old female, known case of type 1 diabetes mellitus, she came to emergency department with presenting with diabetic ketoacidosis, and at emergency her serum creatinine was 1.1. At presentation her serum creatinine was 1.1, and this accounts, if you plug this in equation of CKD EPI equation, the GFR comes in the range of 80 ml per minute. So let's see the graph of this GFR versus creatinine. So this is the creatinine in y-axis and this is the GFR in x-axis. So normally we have 120 ml per minute. So let's say this is 120, this is 80, this is 60, this is 40, this is 20, this is 0. And here let's say creatinine, serum creatinine is 1, 2, 3, 4 like this. So initially her creatinine was 1.1. So let's say her creatinine was here and her GFR was 80. Now she was a case of diabetic ketoacidosis. She was shifted to ICU, and in ICU after 12 hours we checked her serum creatinine and it was 1.7. So this comes to GFR of about 40. So from 80 her creatinine became 1.7 and her GFR now became 40. So this came here. You know this graph. When the GFR, as the GFR begins dropping, there is sharp rise in creatinine. But in the initial portion, even if there is large drop in GFR, there is minimal rise in creatinine. So this is the problem with using creatinine. if you are waiting for creatinine to rise, your GFR, see, it has dropped from 80 to 40. 80 to 40 means half dropped, but the creatinine rise was only 1.7, even less than 2, and you are not able to detect acute kidney injury in the beginning. And let's say her baseline creatinine was 0.7. We don't have her baseline report. So if you plug in this 0.7 creatinine, her GFR comes to 120. So she had healthy kidney initially, and her GFR was 120, and she came to emergency with GFR 80, and when she was shifted to, her GFR has become 40. So from 120 to 40, so 40 divided by 120, it means that her 2/3 portion of kidney has stopped functioning. Then you detected that she has insult to her kidney. That has happened acutely. But her 2/3 kidney are gone. Those 2/3 nephrons are not able to do their job. So this is her kidney, and divide in 3 parts. So 2/3 part of this and 2/3 part of this has stopped functioning. Only this much portion is remaining nephrons that are able to do job of filtering, acidification, or other processes, other metabolic functions, synthetic functions of kidney. So only this much portion is doing job. And in the ICU, now you detected AKI, and you infused fluids, you removed the offending antibiotics, you did renal modification of those antibiotics like vancomycin or other drugs, and there now you are trying to stop the progression of this acute kidney injury. So what can be the course after this? So see, this much portions of these nephrons are not functioning. So there can be chance that those tubular epithelial cells can undergo necrosis. And once it undergo necrosis, there will be inflammation. And once inflammation, there is chance that fibrosis will occur. And after fibrosis will occur, you know what will happen. Once fibrosis, those nephrons will not recover. But there is chance that those tubular epithelial cells regenerate, and those nephrons will be again be able to function their jobs. There is chance. So we have seen many cases that returned back, but we also have seen many cases that had gone into acute kidney disease, and she required multiple times renal replacement therapy with dialysis support. And we also have seen many cases that has went to chronic kidney disease. And once this young patient goes into chronic kidney disease, then you can understand what will be her quality of life, health status afterwards. That's why we need to detect this kidney injury early. And these you saw that using creatinine and using urine output criteria, still we are not able to detect injury to these nephrons in the early stage. So researchers thought that we should develop some markers that we can estimate either in the blood or in the urine that is not such invasive, and we can detect these injury in the early stage even before there is rise in creatinine. And they developed many markers. Currently I think even more than 100 markers are available both in the serum and in the urine that we can utilize to detect whether these epithelial cells are undergoing necrosis, or if there is ischemia, even not undergoing necrosis, they will detect. Even those proteins and involved in cell cycles are used for detection in the serum and the urine. So let's talk about what are some of those markers. And these markers are commercially available in many countries. in our setup these are not available, but in other parts of the world those are also commercially available and they are used most often. And there has been currently also undergoing many studies, and previously also many studies investigating these biomarkers have been done, and this has shown to reduce the length of stay in the hospital, length of stay in the ICU. If you detect early, you can intervene early, and thus the length of stay can be reduced. And you can also predict whether she will go to chronic kidney disease, whether she will require renal replacement therapy or not. Okay, so you may be thinking, how cost effective is this? We are using creatinine urine output, but how cost effective will be this using these biomarkers? Let's say if you can only reduce the stay of duration in the ICU by 1 to 2 days, even in less cost than that, these biomarkers can be done. And these biomarkers, once we do, then we don't repeat that. That is not the case. We have to repeat these biomarkers, and we also have to use these biomarkers in combination, because only one biomarker does not tell everything. So what are the biomarkers, other biomarkers available? One biomarker is cystatin C, and you know that creatinine is produced by myocytes, muscle cells of our body, but this cystatin C is produced by all nucleated cells of our body, and except RBC, which cell in our body is not nucleated. So, and it is better predictor of GFR. You know that creatinine is secreted in the tubule. If creatinine is secreted in the tubule, what will occur? It will detect low creatinine in the serum, and it will underestimate GFR. And you know that in sarcopenic patients, in patients with chronic liver disease, the creatinine is low. So we think that he has not had kidney injury, but he has undergone acute tubular necrosis, and you are not able to detect with creatinine. So cystatin C is a better marker than using creatinine. And what are other biomarkers? So some biomarkers are released from proximal tubular epithelial cells. Some are released from this ascending limb of loop of Henle, some from descending, from distal convoluted tubule. So when these cells undergo stress, necrosis, they release the protein molecules inside it, and we detect in the serum and urine. So other biomarkers are liver fatty acid binding protein, liver fatty acid binding protein. Other is kidney injury molecule 1. Other is tissue inhibitor of metalloproteinase 2. Another is insulin like growth factor protein binding 7. I have written the short form of this. Another is albumin, beta 2 microglobulin, and this tissue inhibitor of metalloproteinase 2 and insulin like growth factor binding 7, this in combination are commercially available even in our neighboring countries, and they are using this in the commercial name of nephrocheck. They test with the urine, and this has been shown in many studies, even in patients undergoing cardiac surgery. If they check initially with that, when the surgeon gives incision to the sternum, and when you check with the urine, it is detectable at that early stage, and you can predict with that he will develop AKI, he will require renal replacement therapy, and whether the duration of stay due to this kidney injury will be prolonged or not. Although I am saying these things, but there has been many controversies regarding these biomarkers. If you read those research articles, then we will know. But basically, we are trying to understand in short forms, in abbreviated forms, what are these biomarkers. So don't delve deeper into that currently. So I told that these biomarkers can be used for diagnostic purpose as well as prognostic purpose. So prognostic, for prognosis, these what I wrote, these were for diagnostic markers. And what are the prognostic markers that we use? One is called SUPAR. SUPAR stands for soluble urokinase plasminogen activator receptor. This receptor is expressed on endothelial cells, on podocytes, and even on monocytes and lymphocytes. When there is necrosis and when there is inflammation, those immune mediator cells comes, and on the receptors, on the cell membrane, these receptors are present and these are released in the serum, and we can detect these molecules in the serum, and we can tell that there is active inflammation currently undergoing at this stage in the kidney, and this will prolong the length of stay of this patient. This patient will require renal replacement therapy. Although at this stage urine output is not decreased and serum creatinine has not risen. Another is DCOF3. Another is TAM horsefall protein, that is also called uromodulin. So we use this. You know that this TAM horsefall protein is secreted from thick ascending limb of loop apelli and distal convoluted tubule. Normally also these are secreted, but in those injury these are secreted in high concentration. So if you estimate this, how much these are secreted in ratio to creatinine, how much creatinine is in the urine and how much are these uromodulin proteins. So if it is high concentration, you can predict that injury is high, and you can correlate with this concentration how much inflammation, how much injury is that. And there has been some studies that have compared this, and they have found that there is good correlation between degree of injury and degree of concentration of rise is these molecules. Another is plasma NGAL. NGAL stands for neutrophil gelatinase associated lipocalin. Neutrophil gelatinase associated lipocalin. This you can detect both in serum and urine, and this also shows good correlation with the injury.